Advantages over fluorescein angiography. Whilst FA is an excellent method of studying the retinal circulation, it is of limited use in delineating the choroidal vasculature, due principally to masking by the RPE. In contrast, the near-infrared light utilized in indocyanine green angiography (ICGA) penetrates ocular pigments such as melanin and xanthophyll, as well as exudate and thin layers of subretinal blood, making this technique eminently suitable. An additional factor is that about 98% of ICG molecules bind to serum protein, mainly albumin, considerably higher than the binding of fluorescein. As choriocapillaris fenestrations are impermeable to larger protein molecules, most ICG is retained within choroidal vessels. Infrared light is also scattered less than visible light, making ICGA superior to FA in eyes with media opacity. Image capture. ICG fluorescence is only 1/25 that of fluorescein, so modern digital ICGA uses high-sensitivity videoangiographic image capture by means of an appropriately adapted camera. Both the excitation 805 nanometers and emission 835 nanometers filters are set at infrared wavelengths. Alternatively, scanning laser ophthalmoscopy (SLO) systems provide high-contrast images, with less scattering of light and fast image acquisition rates, facilitating high-quality ICG video. Figure 14.21 Principles of indocyanine green angiography. The technique is similar to that of FA, but with an increased emphasis on the acquisition of later images, up to about 45 minutes, than with FA. A dose of 25 to 50 mg in 1 to 2 ml water for injection is used. Phases of ICGA. A. Early, up to 60 seconds post-injection. B. Early mid-phase 1 to 3 minutes. C. Late mid-phase 3 to 15 minutes. And D. Late phase 15 to 45 minutes. Figure 14.22 Normal fluorescein angiogram, left, with normal indocyanine green angiogram, right. A. Early mid-phase 1 to 3 minutes, showing greater prominence of choroidal veins as well as retinal vessels. B. Late mid-phase 3 to 15 minutes, showing fading of choroidal vessels but retinal vessels are still visible. Diffuse tissue staining is also present. Adverse effects. ICGA is generally better tolerated than FA. Nausea, vomiting and urticaria are uncommon, but anaphylaxis probably occurs with approximately equal incidence to FA. Serious reactions are exceptionally rare. ICG contains iodide and so should not be given to patients allergic to iodine, or possibly shellfish. Iodine-free preparations such as indocyanine green are available. ICGA is relatively contraindicated in liver disease, excretion is hepatic, and as with FA in patients with a history of a severe reaction to any allergen, moderate or severe asthma and significant cardiac disease. Its safety in pregnancy has not been established. Diagnosis. Examples of pathological images are shown under the discussion of individual conditions where relevant. Hyperfluorescence, a window defect similar to those seen with FA. Leakage from retinal or choroidal vessels. The optic nerve head or the RPE gives rise to tissue staining or to pooling. Abnormal retinal or choroidal vessels with an anomalous morphology and/or exhibiting greater fluorescence than normal. Figure 14.23 ICGA image showing hyperfluorescence due to polyps, arrow, and leakage in polypoidal choroidal vasculopathy. Hypofluorescence blockage, masking, of fluorescence. Pigment and blood are self-evident causes, but fibrosis, infiltrate, exudate and serous fluid also block fluorescence. A particular phenomenon to note is that in contrast to its FA appearance, a pigment epithelial detachment appears predominantly hypofluorescent on ICGA. Filling defect due to obstruction or loss of choroidal or retinal circulation. Choriocapillaris non-perfusion manifests as dark geographic areas of hypofluorescence, whereas choroidal stromal foci impair diffusion of the ICG molecule and manifests as regular round evenly distributed dark dots in the early phase. Indications: polypoidal choroidal vasculopathy (PCV). ICGA is far superior to FA for the imaging of PCV. Exudative age-related macular degeneration (AMD). Conventional FA remains the primary method of assessment, but ICGA can be a useful adjunct, particularly if PCV is suspected. Retinal angiomatous proliferation. ICGA is diagnostic in most cases, showing a hot spot in mid and/or late frames. Chronic central serous chorioretinopathy, in which it is often difficult to interpret areas of leakage on FA. However, ICGA shows choroidal leakage and the presence of dilated choroidal vessels. Previously unidentified lesions elsewhere in the fundus are also frequently visible using ICGA. Posterior uveitis. ICGA can provide useful information beyond that available from FA in relation to diagnosis and the extent of disease involvement. Choroidal tumors may be imaged effectively, but ICGA is inferior to clinical assessment for diagnosis. Breaks in Bruch membrane such as lacquer cracks and angioid streaks are more effectively defined on ICGA than on FA, if FA is contraindicated.